We are going to talk about spasmodic dysphonia, and while we're going through the slides, I want you to keep in mind the effect that this would have on maybe someone that you love, especially when you communicate via telephone, how much comfort you get from hearing your loved one's voice on the other end.
Here are some general facts about spasmodic dysphonia. I just want to highlight the fact that 90% of individuals who have it will have the adductor spasmodic dysphonia, and also I wanted to emphasize that this is easily misdiagnosed, and less than 10% of individuals diagnosed with spasmodic dysphonia actually have it.
The objectives we're going to be covering today will be the definition of spasmodic dysphonia, or SD, the structure and function, the classifications, there's different types of spasmodic dysphonia, evaluation, what's going to happen once these patients appear in your clinic or in any setting that you would be evaluating them, what the possible treatments that are available and their effectiveness, the current research and where future research needs to go, and then we'll wrap it up with a review.
Spasmodic dysphonia is extremely rare, and it results from involuntary muscle spasms within the larynx during phonation, and it can be characterized as hyperfunction, hypofunction, or even irregular vocal fold movements. An individual may experience normal voicing during certain activities such as singing or speaking to their cat. It may have a sudden onset, but typically it gradually progresses. And also I want to emphasize that it is a neurogenic disorder. It was first recognized in 1871 and was believed to be psychogenic for 100 years, but it is neurogenic. SD is usually idiopathic, with the exception to individuals who have Wilson's disease or even sometimes multiple sclerosis. Individuals who have SD, in that case, it is treatable. As far as the structures go, the laryngeal structure is normal. There's not a problem with the structure itself. However, an individual may sometimes have secondary changes to the structure due to vocal hyperfunction and compensatory behaviors. So overall, the function of the larynx muscles are going to experience these spasms that are going to squeeze the muscles during phonation too tight or not enough. The first type of spasmodic dysphonia is abductor, and that affects the ability of the vocal folds to involuntarily stay open. The second type is adductor, which is the most common. It's very inconsistent. The involuntary intrinsic laryngeal muscles are going to spasm, and those vocal cords are going to squeeze and stiffen and close tightly. And then you could have a combination of the two, which is mixed spasmodic dysphonia. So the difference in the vocal quality: with abductor, you're going to hear a strained, strangled voice quality, and with abductor spasmodic dysphonia, you're going to have sudden bursts of breath affecting the vocal quality. So it's going to sound more like a whispery, breathy voice.
Christy Ludlow, a pioneer in the field now of spasmodic dysphonia, wrote this article and pinpointed these three things that are most important. You want to screen a patient using some specific questions. Some of those are specific to their quality of life and things like that. If you find that there is something in there that makes you feel susceptible that it could be possibly spasmodic dysphonia, you're going to move to the next step, which is speech examination. To do one of those, you're going to have subjective as well as objective measures. And if you're still leaning towards spasmodic dysphonia, to get a definite diagnosis, you can move to the next step and get a nasolaryngoscopy or a video stroboscopy to take a look at the vocal folds, and you'll know for sure, looking at the imaging, whether it is spasmodic dysphonia versus tremor or muscle tension dysphonia. This slide is a for your information slide. These are some of the screening questions that Christy Ludlow identified. as being able to give you a good idea of whether they're leaning more towards spasmodic dysphonia or some other possible neurological disorder. And like any evaluation, you want a good case history, a good neurological assessment, a voice assessment. You want to listen to them doing a variety of tasks. You can also, again, like I said, use video stroboscopy or nasolaryngoscopy to make it for sure, to know for sure that you're diagnosing with the correct diagnosis. You want to use your perceptual judgment on scales and instrument measures. So you want to make sure that you're taking your clinical observations and comparing them to some type of norms. Again, we're talking about a team, so we have an otolaryngologist, we want a neurologist that specializes in spasmodic dysphonia, and of course there'll be a speech-language pathologist to make comments and judgments based on their vocal presentation. This is another for your information slide. This was taken from the course textbook table from chapter 4. This gives you specific areas where essential tremor, vocal hyperfunction or muscle tension dysphonia, and adductor spasmodic dysphonia, how they're alike and how they're different. And I think it's a good way to look at it when you know there's so much misdiagnosis that goes on.
Listening to the auditory perceptual features is very important. You can have the patient produce voice-loaded and voiceless-loaded utterances, and you will see the greatest effect on voiceless for adductor. You will see a greater effect on voice-loaded for abductor, and you will see voice and voiceless utterances are equally effective for individuals who have muscle dysphonia. Unfortunately, there is no cure for spasmodic dysphonia. However, voice therapy may help to improve compensatory behaviors. According to Boone, there are some possible techniques that can be applied, such as the ones listed on this slide. However, there's very little efficacy for using only voice therapy to treat spasmodic dysphonia. Instead, it's typically used following surgical procedures, and another study found that there wasn't really a significant benefit for those individuals who participated in voice therapy after receiving the injections. So keep that in mind. Again, the voice therapy can help to fix hyperfunctional compensatory behaviors that had developed over time from pushing the voice out, but I guess it doesn't typically generalize outside the clinic setting. Botox injections are the primary approach used today to treat SD. Those injections are usually done every 4 to 6 months when the tightness reappears. Another option is surgical resectioning of the recurrent laryngeal nerve, and temporarily they're going to paralyze the vocal folds and then make observations as to whether the phonation and ease of airflow improved. If it did, they'll cut the recurrent laryngeal nerve. If not, then if the voice becomes breathy, then they'll explore other options such as voice therapy. And another option is vocal fold surgery.
The field of research right now for spasmodic dysphonia is very controversial. There's a lot of different views that people are taking on treatment of this, and really the way that they're trying to find treatments and cures. We're really looking at how to help the symptoms and not how to cure spasmodic dysphonia overall. So the information now is sparse based on long-term effects. We don't have anything that's more effective than Botox injections. We need controlled treatment trials and research. We need a comparison group. We need to have appropriate outcome measures, subjective as well as objective. We need to try some new drugs that have been proven to be effective within the laboratory, and then surgical procedures that may be somewhat invasive, but again, it goes back to these long-term effects. How effective is this treatment going to be for our patient? This is a case study on Diane Rehm. She's a radio personality for National Public Radio. She was diagnosed with adductor spasmodic dysphonia in 1998. The first symptom she observed was an irritable cough. Most people thought she had a tremor. She was asked many times during interviews if she was nervous. She was not at all. This has significantly impacted her life. She is on anxiety and depression medication. She does require Botox injections every 3 months.
Natasha Trethewey is the first U.S. poet laureate to move to Washington and work out at the Library of Congress since the position was established in 1986. She's the first.
The take-home message is don't try to be Wonder Woman. Sit with a team, think about it, ask for help when you're unsure about the diagnosis, and have somebody mentor you in making the best sound clinical decision you possibly can.
Just to recap, these are the following topics that we reviewed about spasmodic dysphonia. Overall, spasmodic dysphonia is a rare neurologic disorder that is not curable. And if you're unsure whether an individual has SD, seek advice from mentors or other experienced clinicians because it is very easy to misdiagnose this disorder. The next 3 slides include our references and resources. We hope you enjoyed learning about spasmodic dysphonia. Thank you. At this time, does anybody have any questions or anything that they would like to share about spasmodic dysphonia?